Good morning, good afternoon, good evening, everybody. Thank you so much for being here on a Saturday morning, afternoon, taking the time on the weekend to join us. On behalf of the Wiskott-Aldrich Foundation, I'd like to welcome each and every one of you here, especially our speaker, Dr. Susan Prokop, and our moderator, Dr. Fabio Kindari. And a very special welcome to our Wiskott families around the world. This time we have special guests. We have Barb Ballard, who is the president and founder of the Skid Foundation. We would like to welcome her and the Skid families to this group today to listen to this talk. We would like to also welcome Akiva. Akiva Zablocki is the president and founder of the Hyper IgM Foundation. Very much welcome to this group today, and very welcome to the Hyper IgM families who are here with us today. We would also like to welcome Elizabeth from the Canada Immune Foundation. I'm sorry, I'm butchering it, but you're the founder and president of that foundation. We would like to welcome you to this group too. With that, I would just like to say a few words about the Wiskott-Aldrich Foundation. We're a volunteer-run nonprofit organization with a mission to improve the lives and futures of individuals affected by wars through research, through education, and compassionate support. We have a few announcements to make before we start our talk. Our first announcement, and very exciting, we're launching a support group, and perfect to this talk, we're launching a support group exclusively for WAS warriors, and this will be led by Dr. Simon Tabji and Dr. Matt Snyder. Simon, would you like to say a few words about this group?
Hi, Samati. Thank you. Good morning, everybody. So both Matt and myself are both on the Wiskott-Aldrich Foundation board, and we've been working over the past couple months in order to get a Facebook page together for warriors and survivors. The whole point of the Facebook page is for patients who are seeking guidance and connection as they navigate life after diagnosis and treatment. I know myself, after entering into adulthood, kind of was in limbo until I really met you, Samati, and was directed as to who I should be following up with, what I should be doing, how I should still be taking care of myself. So the Facebook page is going to be an open forum for adult survivors who are looking and who have questions or concerns about long-term health, follow-up, fertility, family planning, a lifestyle, mental well-being, your future, anything that you really want to discuss, we are here for you. Both Matt and myself are also on the medical side. So we might be able to provide a little bit better knowledge and understanding to folks. I do want to emphasize that the point of the group is not to replace any type of medical advice. It's just a community for compassion, resources, and lived wisdom through those who have already been through it, in order to really help guide those who are going through it. So we're excited. We're hoping to launch it hopefully within the next week or two. We're just finalizing the last touch-ups for it, but we're excited. So it should be good.
Thank you, Simon. That was great, and yes, looking forward to this group getting together. The next announcement is, why can I move the slides? There we go. So our next webinar will be on September the 26th. It will be on prevention and management of infections in Wiskott. This will include prophylaxis, post-transplant, post-gene therapy, all of those, the things, the niggly questions we have. My child has CMV, add no, all of those questions will be answered. Dr. Freeman will be here to speak about it, and Dr. Kindati will be moderating. And with that, before I hand it off to Dr. Kindari, just a quick disclaimer that the information presented today does not substitute the medical advice from you or your child's physician. Each patient is unique, and the information presented may not be applicable to every patient. Always consult with your physician and do not disregard medical advice based upon any information that is presented in this session. With that, I have the pleasure of introducing Dr. Fabio Candari, who does not need any introduction at all, especially in this group. He is the full professor of medicine at the University of Lausanne and head physician in the Division of Immunology and Allergy in the Lausanne University Hospital in Lausanne, Switzerland. He's very well known to particularly people in the US because he worked in the NIH until 2014. And during this time was when he helped start the Wiskott-Aldrich Foundation and became the chairman of the Scientific Advisory Committee. He used to work at the NIH as the head of the NHGRI, and I think he was the head of the head of the immunity division of immunity at the NHGRI. And with that, I'm happy to hand this over to Dr. Kendari. Dr. Kendari, all yours.
Great. Thank you very much, Sumati. Welcome all to this appointment, what is it become an appointment of these seminars on the Saturdays that are hosted by the Wiskott-Aldrich Foundation, and that provide a lot of good information and also I sense the community. I feel it over the months. Today we are very fortunate to have with us Dr. Susan Prokop, who is a prominent pediatric hematologist and oncologist. She is an associate professor at Harvard Medical School and as a position also at the Dana-Farber Boston Children Cancer Dana-Farber Institute, where she works on children cancer and blood disorders. She's an expert on bone marrow transplantation, and today she will tell us why it's important to continue to pay attention to the condition after gene therapy or after bone marrow transplant, whatever is the case. Susan, I'll let you take it all away.
Thank you so much for the kind introduction, and it's such a pleasure to be here. Let me just share my slides. Is everybody seeing them in the full screen view?
Yes, that's good.
Great. So I'm going to spend the first part of this session and then leave, I hope, plenty of time for your questions, because I think that's the most important part of this type of session. But I'm going to spend the first part sort of talking about just a couple slides on current outcomes and how good some of our outcomes for curative therapy for Wiskott are, and then go through sort of how we here Boston Children's approach thinking about late effects and preparing boys after a treatment for Wiskott, as well as other patients after curative therapy for immune deficiencies for lifelong follow-up. And so, as we know, the boys without definitive therapy for Wiskott potentially have shortened survival. And this slide is just to say, and I think it's important to position this because I am going to be talking about a lot of things that can happen after our curative therapies. And it can be very daunting, and people can be left with the sort of question of, why am I having this therapy up front if it has all these potential complications? So I do think it's important to keep in mind that without curative therapy, increasingly we have data to suggest that there is over time ongoing acquisition of events related in this slide to Wiskott, but for other immune deficiencies to those as well. As I mentioned, our curative therapies for Wiskott-Aldrich syndrome, both from the transplant as well as now gene therapy, have improved over time. And some recent publications from the PIDTC and the EBMT group in Europe really show that for matched, either matched sibling and matched related donor transplants, that overall survival approaches 90% and higher than that in the setting of matched related donor transplant. The thing we're going to talk about today, and this is it's in SCID, not in Wiskott, but it really gives you a sense of what the issue is. And this is a large historical study done by the PIDTC in patients who underwent transplant for severe combined immune deficiency, and looked at just shy of 400 patients and looked at late effects after transplant. So not the sort of acute toxicity of transplant, but sort of more the cumulative events that can happen. You can see that at 2 years, 25% of patients had at least one event, but that incidence increased over time. And so by 15 years, 41% of these patients had an event. And by event, we don't necessarily mean life-threatening events. We're talking about events that require attention, require a visit to a physician at least once a year. The most common late event in this cohort, and remember, these are in the SCID cohort, these are frequently patients who are transplanted in infancy. But the most common late events were neurologic or neurodevelopment and dental. And those who had poor immune reconstitution by at least 2 years were found to have lower adult height, but that was about the only other consistent finding in this group. And so why do we care about long-term follow-up, and how do we sort of approach long-term follow-up? And again, this is sort of slanted by what our approach in our transplant survivorship program here is at Boston Children's. And so what we attempt to do for each patient is think about the individualized risks that they are at for late complications. So we look at what their immune function is like, and there's some children who have very durable, high quality immune function. There are others who are at risk for waning immune function over time. And so we think about that. We think about the risk of any disease-specific risks, such as Wiskott late autoimmunity that can be seen especially in boys with incomplete chimerism, and then comorbidities to infections that they had peri-transplant or other events that happened peri-transplant, and the late effects of the conditioning that most of these boys have received. And then what we do is, after we've done this type of assessment, we provide a passport. So whether these boys are going to continue to have their follow-up care here with our team, or whether they're going to transition to adult care, whether they're going to move to another area, another country, or whether they're going to switch from having their care at a specialized center, which we, in a maybe biased way, recommend, or whether they're going to have their care through a more general care center. We provide a passport that includes specific recommendations for lifelong monitoring. One piece that I call out here is lifelong monitoring of immune function, and that can be a little challenging for the general care provider compared to some of the other components of long-term follow-up that I'm going to talk about. And so the frequency of lifelong monitoring of immune function, typically we recommend for the first 5 years, at least annual assessments. Once somebody has immune reconstituted or has stably immune reconstituted. But then after those first 5 years, it can be every year, every 2 years, or even every 4 or 5 years, but needs to be dependent on frequency of infections, on whether somebody already has mixed chimerism or autoimmunity in the post-curative therapy period. And so the components of this lifelong monitoring of immune function include lineage-specific chimerism, meaning looking at the chimerism in a marker of the stem cell population with the neutrophils, as well as T cell, B cell, and NK cell numbers, the number of new or naive T cells, and then we make consideration, especially early and in younger children, of monitoring for production of new T cells. And then looking at the T cell function. So looking at how those T cells are responding to specific infectious triggers, both whether somebody's clearing infection or not, but also in confrontational in vitro testing.
And as soon as we're finished, your ambition just met its match with Robin Hood.
And then for patients who remain on immune globulin replacement therapy, there's specialized testing that we do and approaches to vaccination in this population that are emerging over time and pretty rapidly emerging. And so again, one of the reasons for long-term follow-up and specifically long-term monitoring of immune function is that our ability to monitor specific components and functionality of different parts of the immune system have changed rapidly in the last 5 years. And, I think one real example is that we are changing our approach, at least here locally and some other centers, changing our approach to vaccination of boys, even those on consistent IVIG replacement or Hizentra replacement. So I'm just going to walk through it. As I mentioned, that I'm going to walk through sort of a couple of the specific organs that we think about, how we monitor, how we prevent. And so when we think about looking for poor or waning immunity in either T cells or B cells, the things that put people at risk for having this happen are typically things that happen early peri-transplant. So having a transplant from an HLA non-identical donor, having a T-depleted transplant, having splenectomy prior to transplant, and having received rituximab. These are all very specific to transplant as opposed to gene therapy. But we can, and I did not include slides here on gene therapy, and I apologize, but we can talk about that in the question and answer. And so the events we're looking for are events of mixed chimerism, infection, and autoimmunity. And there's very close monitoring until somebody is reconstituted. And then, as I mentioned, the frequency of that monitoring of immune function can be tailored to the patient and to what their immunity looks like. In terms of prevention and intervention, there's prophylaxis that we recommend until people are immune reconstituted. There are guidelines for revaccination that can be time-based or immune milestone-based. And we are very aggressive about looking at titers in an ongoing way and assessing whether somebody needs booster vaccines that may be different from what are recommended in the routine population. And then I'll talk a little bit about specific things we think about in different organs, and then about some of the sort of things we pay a lot of attention to in terms of endocrine issues and fertility. But to start with sort of the heart and lungs, liver and kidney. So on the side, I've put sort of approximate instances of late effects in each of these organ systems, but I will say, unfortunately, our data is incomplete and very incomplete, and we need people like the people in this group who are long-term out from these therapies to help us understand what the frequency is, because when we are closely looking at people who have problems, then we see a high incidence. When we are looking at a whole group that includes people who don't have any identified problems, maybe that the incidence is actually lower than what we've been able to identify. So for issues with lungs, late, typically early exposure, early evidence of graft versus host disease, busulfan exposure can trigger some late lung damage, and pre-transplant lung disease as an example. And the late events we look for with monitoring of pulmonary function testing. And then there are things we do in terms of prevention and intervention, such as very nuanced discussion about tobacco exposure, including secondary exposure, and early referral to pulmonologists, and especially for any change in those yearly pulmonary function tests, and a low threshold to institute things like a pulmonary toilet regimen that's just, use of inhalers with respiratory tract infections and things like that. And I can share these slides at some point with a group or do some other way. I wasn't going to walk through each of the triggers and events, but really to highlight that for each of these potential complications, there are things that we can do both from a preventive and intervention perspective. And so really part of the key of monitoring is the idea that there are things that we can do in terms of intervening if something starts to be an issue. Then we focus a lot on growth and development, and I think this is a place to spend a little bit more time. So, and again, this is an example of where closer monitoring and closer assessment of children who've been through transplant and received conditioning in early childhood and infancy has led us to detect that about 5 to 12% of children who've been through transplant for immune deficiency appear to either require extra time on tests or have subtle, sometimes, issues around developmental delay. And again, this is an area where I do think we're over-reporting probably on patients who are receiving more frequent neurocognitive testing and things like that. But certainly, again, there are things we can do for children who have mild developmental delay, and so it's important to identify that. From a growth perspective, the busulfan conditioning and alkylators can affect growth. This is less true today with the busulfan dosing that we're using today than it was historically, and certainly less true than it is for combined alkylator use or historical use with radiation therapy, but it can still be an issue. And so things like annual bone age testing and referral for potential growth hormone, while there's still growth potential, are all important. Referring somebody for potential growth hormone when they've reached their adult stature is less effective than referring somebody who's not staying on their growth trajectory. Similarly, with bone health, referring somebody with evidence of poor bone health early on, there's much more that can be done from an intervention perspective in terms of weight bearing, exercise, and calcium and vitamin D, and even bisphosphonates. And there are both gonadal and non-gonadal endocrine toxicities of our therapies. And so we test on an annual basis for thyroid function testing, and at least once every 3 years, we do a morning cortisol to look at adrenal function. And then the gonadal toxicity is something that we spend a lot of time both talking about, but also thinking about prior to transplant. So there are increasing approaches to trying to, it's not really preserving fertility, it's preserving the option of later fertility. So there isn't yet a way to prevent, for instance, busulfan from having a toxic effect on later male fertility. But there is a way, and there are some experimental ways and some defined ways to obtaining testicular tissue or sperm prior to transplant, prior to exposure to these toxic medications, and storing them in a frozen setting. And so we have a protocol for that here. That's a multi-center trial in the US that many centers have access to. And there's a similar process for girls for harvesting prior to exposure of ovarian tissue and freezing it for future use. The incidence of dental issues is quite high for those exposed to busulfan in infancy and as toddlers prior to the full development of the secondary teeth. And so this typically doesn't affect the primary teeth, but from a prevention perspective, it has again, is a place where we recommend avoiding tobacco use and sugared beverages. And dentists who are informed about the potential effects on the secondary teeth have a different approach to primary or your deciduous teeth and the care of those, have a different approach to, for instance, whether you remove wisdom teeth if they've formed, or whether you leave them with the idea that there may be other gaps in somebody's tooth development. And so again, really what we focus on and what many centers and long-term follow-up programs are focusing on is trying to personalize the risk, understanding the underlying diagnosis, the conditioning regimen that somebody received and its intensity, and whether or not in the transplant setting they had chronic graft versus host disease. And this specific sort of personalized risk in the gene therapy realm is more about ongoing assessment of genotoxicity. And then one example of where we can really try to get at personalized risk is when we think about busulfan exposure. And so there are ways to calculate busulfan exposure. The way we do it is calculated as a cyclophosphamide equivalent dose. And you can do this with all of the alkylators, including, for instance, Milfin and Diatepa. And then you get to a cyclophosphamide equivalent dose. And as you can see down here below this, the toxicity to the gonads occurs at a lower exposure in males than in females. So males are much more likely to have impaired fertility even after lower dose busulfan exposures. There's also a St. Jude calculator. I think the problem with the St. Jude calculator is that it's not transplant specific. And so we know that allogeneic transplant imposes its own increased risk of infertility based on the combination of medications that boys are getting, as that's a little bit different than just those exposures to, for instance, melphalan or cyclophosphamide. And so this is an example of what we can generate from that type of calculator. And so in isolation, for instance, a cyclophosphamide dose of less than 4 has a minimally increased risk of infertility in boys, but there is a high level of risk if the exposure is greater than or equal to 4. And in the setting of transplant, that risk also increases. And this is just to say that for girls, the risk is still increases with increasing exposure, but the lower level exposure is higher for girls than for boys. And so one thing I just want to touch on, because people frequently ask about whether treosulfan is better. And from some of the acute toxicity of transplant, treosulfan can appear to have a lower incidence of, for instance, hepatotoxicity. But, and in terms of spontaneous puberty, and achievement of Tanner stage 4 or 5, treosulfan does appear to be a little bit less toxic than busulfan. The caveat here is that, as this group probably knows, in a fairly large retrospective assessment by the EBMT, for Wiskott specifically, the outcomes were a little better with busulfan-based conditioning rather than treosulfan-based conditioning. So I'm optimistic that we'll get there with treosulfan for boys with Wiskott, but I don't think we're fully there yet. And again, these differences across these different studies were not, there was only one that was statistically significantly different. And so again, when we think about long-term follow-up in our program, while there is potential for accumulation of events, long-term studies are increasingly demonstrating improvement in overall health and patient-reported quality of life compared to non-transplanted diseases, where transplant is an option as opposed to a necessity. I think it's really important, as I hope I've highlighted, that children who've been through this type of therapy need ongoing assessment by providers with expertise, or at a minimum, sort of this idea of an individualized passport. And here we really feel that approach empowers parents, teenagers, and adult survivors and thrivers to take control over their own health and to understand and go into even a general practitioner with a list of what they know and think they should be receiving in terms of their follow-up care. And again, we find this is especially valuable to support transitions in care to different centers, to different care providers, and different care settings. And especially, I would say, our adult, even the transplant survivorship programs on the adult side don't have quite the same embedded expertise in terms of what these therapies mean when they're delivered to young children. And so we use this even when we're transitioning a patient from survivorship care here on the pediatric side to our adult colleagues here at DFCI. So I just need to call out the physician and nurse practitioner who run our transplant-specific multidisciplinary survivorship program. And on the oncology side, it's Linda Vrooman, who similarly runs a multidisciplinary survivorship program. And these are clinics that have a weekly cadence. So I hope I've left plenty of time for questions.
Well, thank you very much, Susan. That was fantastic. I will start perhaps with a question of my own, and just to try to give some general ideas to the audience. How late can this late effect appear, or is there a time when after transplant one can say, okay, nothing has happened so far, I'm not going to have problems from now on?
I wish we could say that, but I think our data suggests that that's not the case. And so, and the best data, the best published data for that really is both from that SCID retrospective study that I showed, and also from in the US, there's a pediatric child cancer survivorship group. And so it's a little different because it is cancer, but they are looking at the late effects of these strong therapies we are administering. And they similarly show that children do still accumulate new events over time. You know, I used to talk about this in a very simplistic way of saying it's a little like we've aged your body by, let's say, 10 or for some instances, 20 years. So in families where you have to start worrying about high blood pressure when people are in their 40s or 50s, move it back and start to think about it when kids are in their 20s or 30s. So I've been saying that now for almost 20 years, and I used to think of it as very simplistic, but there's actually now data coming out about the biology of aging and what happens to cells as we age. And it's actually maybe not so simplistic. It is actually somewhat true on a biologic sense, that a little bit of what we are doing with these strong therapies is aging somebody a little bit.
That's right. And so as a follow-up to this argument, there was a question in the chat regarding, this long-term follow-up need to happen. Of course, you showed it very, very nicely. But what happens if the family has lost contact with the transplant center or moved away, or the transplanter themselves are no longer there? How do you deal with that situation?
So I think there are sort of two pathways or more, but there are at least two pathways to deal with that. One is, so I just saw somebody recently who had had no transplant specific follow-up for about 20 years and had had some things followed up, some things not. It's not hard. It takes several hours to sort of recapture that and get somebody back on kind of a track, but it's not impossible at all. So just because there's been a gap doesn't mean that it's not possible to sort of essentially redo a passport and say, this is what we would be doing on a annual basis, once every 5 years, whichever components we would recommend following on whatever cadence. I do think there are published guidelines around what sort of long-term follow-up best models are, and so people can, providers can share that with a patient, even one who's been lost to follow-up. I think they tend to be a little complex for a primary care provider in a medicine setting to just pull those up. We've tried to make them easy for those people, but I'm not sure they are. But I think they're theoretically accessible for even them.
I find this idea of the passport very, very useful, very, very smart. Is that something that is available or applied throughout the US, or also outside of the US, or is the Boston thing?
I think a couple centers are doing things like this. So, we all know that we see more of our patients at the first year time point, at the second year time point even, and then that decreases over time. So I think more people, especially with the use of more easily accessible electronic medical records, our long-term follow-up colleagues, and I've seen this from other centers as well, are putting something like this into their note every time they see a patient, so that if through Care Everywhere or through having access to the electronic medical record, other care providers can see that, the patient can see that.
And regarding also a question in the chat, is there any language about dental care in that passport, or something that you can share that patients and family can use to sensitize their dentists to the dental problems?
Yeah, so a lot of it is around sort of so there's a paragraph that's really about the importance of preemptive management of things like high blood pressure. Samantha, I can share it with you after this, and you can send it to the group if that's helpful.
Yes,
that would be great. Thank you.
Yeah.
Okay. And regarding the growth post-transplant, what can be done for it if there is a growth deficiency in the patients that receive the transplant?
So there are a couple of approaches. As I mentioned, I think the most intervenable issue is if somebody is growth hormone deficient, and knowing that ideally when you have at least 4 or 5 years before puberty and before sort of the growth curve is going to slow down anyway, and the bones sort of reach the end plates fuse so that the potential for growth will decrease. So knowing that, like I said, like 4 years before that, so that you can have thoughtful conversations about whether it makes sense to use growth hormone or not. And there's some non-standard approaches to using growth hormone that endocrinologists are usually open to at least discussing using growth hormone, for instance, in somebody who's not truly growth hormone deficient. Things like that. I think there are people on this call who can probably speak better to that than I.
And there is a very smart question about what you just said, that the chemotherapy basically is aging, our patients. So should the standard, what do you call it, stepstones that we all go through when we are 50 or when you're 60, should they be should they happen before in these patients?
So our group typically recommends, for instance, screening for colon cancer, at least by the stool card type approach, when people enter their 40s instead of 50s. So it's some of that, yes. And being, I think it's more than even that, it's being a little bit more thoughtful about somebody's family history in terms of those risks. And so, if there's no concern for a family history of colon cancer or diverticulitis or anything like that, you may still decide to start screening at 50, but it should be a thoughtful conversation and a thoughtful decision rather than your body hasn't been through anything significant, so you're with the general population.
And regarding
for women, for girls who go through transplant, that it's very clear that if there's any radiation to the chest involved, that we start breast screening earlier than we otherwise would. But right now, our guidelines for girls who've been through transplant at the peripubertal age do include earlier mammography than would otherwise be recommended.
Great. And does the age of the donor as a factor is a factor in the aging of the patient after transplant?
It is a great question. There are some large studies primarily using unrelated donors, because if you're using a related donor, typically the sibling is going to be closest in age to the recipient, so it can be hard to figure out. So in unrelated donor studies, there's some evidence that older donors, there's a little more risk for those donor cells to become dysfunctional at a slightly younger age, meaning like 10 years earlier than, but we're talking about people who are like transplanted in their 50s from a sibling donor who's in their 60s, or transplanted in their 30s from an unrelated donor who was in their 40s or 50s. It's very hard to know. At this point, we have no evidence that that's true in immune deficiency transplants, but there's a little bit of it, a little bit of a signal.
There was also interest in knowing if there are organ-specific toxicities that people need to worry about in addition to the lungs, like heart, liver, or kidneys. Are those organs that are hit by the conditioning and by the transplant procedure itself?
Yeah, so I think the short answer is yes. There is certainly issues with the liver. For instance, if somebody has had either GVHD that affected the liver, or had veno-occlusive disease, or had issues with the liver peri-transplant, or had iron overload, hepatitis, those things peri-transplant, increase the liver, even if the liver looks normal at 2 years post-transplant, do increase later concerns about liver function. And I think there are things for kidneys with sort of prolonged use of calcineurin inhibitors that you would want to look at. And similarly, the other one was heart. And yes, the biggest issue in terms of cardiac function is around thinking about high cholesterol and things like that. So there's an increased risk for what's called metabolic syndrome, and that can increase the risk of cardiovascular disease. And so just being mindful about those things. And again, it's a lot about being a little bit more aggressive. You know, I think for somebody who hasn't been through this, if they go to their doctor at the age of 40 and their blood pressure is a little high, their doctor will say, we'll see what it is next year or in 6 months. For a population that's been through transplant, we want to be more aggressive than that. We want to recheck in a couple weeks. And if it truly is high, maybe start something and intervene.
Sometimes some questions that had been sent to us before your talk, and there is a general issue about mixed chimerism. How long do we need to worry about? Can you ever be called a stable mixed chimerism, or is once that determination is made, there is always the risk that another procedure would be needed?
I think the short answer is, unfortunately, we don't know. I do think part of why we don't know is that for children who've done well, and this isn't just after transplant for Wiskott-Aldrich, but for children who've done well, who have some mixed chimerism, it's only really in the last 10 or 12 years that we've routinely looked at chimerism in the separate lineages, meaning neutrophils separately from T cells, from B cells. And so the first thing I think we need to know when we're thinking about mixed chimerism is it in the stem cell population itself or not? And how much of it is in the stem cell population. And so, but again, the short answer is we don't know. There are certainly people out there who have had stable mixed chimerism for decades, and we know that. And we know that there are people out there who've had stable mixed chimerism with quite low levels of stem cell chimerism for decades. But we don't know what predicts that it's going to be stable. I think having full chimerism, full donor chimerism in the T cell population is always very reassuring, with having some, at least more than 10% seems to be where we're falling in the myeloid compartment. But beyond, outside of those sort of extreme guidelines, it's hard to know.
And how long should that be monitored? Or how often, it should be monitored?
So what we do here is we do it monthly in people with any evidence of mixed chimerism until 2 years after transplant. And then if it's stable, we switch to like every year.
Every year, okay. You mentioned that...
I haven't hit somebody, I have to say, we've only been doing mixed chimerism for, maybe 8 years here, so total. So I haven't hit somebody where they've been 10 years out and I have to decide whether to still do it every year or not.
Yeah. So you mentioned that there is data that's showing the quality of life after transplant is better than the quality of life of people that did not get transplanted. But is it also true, or have you seen data that says that transplant in this decade, the quality of life after transplant in this decade is better than the one that
Yes.
was present in the decade before?
Yes. The issue is, you have to compare quality of life in this decade. We've got 5 years after transplant, and so you do have to compare it to that same time point. But we do, yes, we do have similar data in this decade. And if anything, I think the toxicity of transplant overall has improved. We are using less double or triple alkylator based transplants in non-malignant disease and Wiskott specifically. It hasn't been common to use radiation in Wiskott-based transplants now for several decades, but there was still some use of low-dose irradiation, even what feels recent from a transplant perspective is 15 years ago.
Then there was a technical question about gene therapy that is being performed now by using busulfan as a conditioning, and why is it not treosulfan being used for that?
So it's an excellent question. So the short answer is that all of the gene therapy studies have been done with busulfan, and so even when they get approved by regulatory agencies, it is with the conditioning of busulfan. I would say, especially when we're targeting lower exposures for some of the gene therapies than full dose busulfan, we have the luxury of monitoring levels and targeting the busulfan exposure to specific levels, which at least here we don't have real-time model-based dosing for treosulfan. And so there are some ways in which it's also more comfortable if you're not using the highest doses of drugs to be using dosing where you get levels and know what the exposure is.
Okay.
But I don't know of any of the current gene therapy trials that are using treosulfan instead.
That's true. And then fertility also was a topic that was really important for people. And I wonder if you can tell us, how you approach it, in your pre-transplant information session with the family. What do you say to them?
So I'm lucky in one regard. We have actually an entire team that manages fertility preservation here. But the initial conversation, it depends a little bit on what regimen somebody is getting and what the certainty of infertility is. I usually start with, we all have patients who have had fertility preserved when we didn't expect to. So from a behavior perspective, these boys need to assume that they are fertile. But from the risk of infertility with myeloablative busulfan, we with model-based dosing, so we really know the range of exposure that boys are receiving. We estimate that the infertility risk is about 80%. And so what we And then depending on the age of the boy, there's sort of 3 different approaches that can be taken if somebody wants to try to preserve fertility. One is freezing of testicular tissue, which is a pretty minor surgery. We typically do it at the time, right at the time of admission, at the time they're having anesthesia anyway. The second for peripubertal boys is what's called sperm extraction, where mature sperm can be extracted from the testicular tissue. And the third is sperm donation. So depending on the age of the boy, there's sort of 3 versions of preservation approaches. The first one, the testicular freezing, there aren't children that have been born with frozen testicular tissue. There are now non-human primates that have been successfully conceived and carried to term from frozen testicular tissue. So I think we all think it's going to happen. But that's sort of where we are.
But
I tend to recommend that people in their thought process err on the side of thinking it's more rather than less likely to happen, and then make a decision around that.
In terms of the visits after transplant, the long-term follow-up process, have you had patients disappearing, lost the follow-up? How do you do, or what do you do to avoid that from happening?
Yes, I'd say historically we had about 30% of patients that were lost to follow-up. That was before we had a transplant-specific survivorship group. Our patients were being seen by the general survivorship program. I think just by virtue of having a transplant-specific survivorship program, it's helped. People think they're getting really transplant-specific care, even in survivorship. And then our survivorship team is pretty aggressive about reaching out to patients when they're due for their follow-up. They're aggressive about scheduling the next follow-up visit when somebody leaves. I think that, even if that exact day doesn't work out, it has it on everybody's calendar in a different way. And then we will, if somebody is moved as part of loss to follow-up, if we're still in touch with them, which has gotten much easier, I will say, in the last 5 to 10 years, because people don't get rid of their cell phone number. We will offer transfer to another survivorship program or to connect with their pediatrician or internal medicine physician, and if it's something the patient wants. So we try.
Yeah. Then there were questions that were sent in about the immune system recovery. How long does it take? And you mentioned what you measure, what you monitor, but how long does it take for immune system to recover?
So in the absence of somebody having had severe graft versus host disease or severe autoimmunity early post-transplant and needing a lot of immune suppression, typically by about 9 months post-transplant, we've weaned the immune suppression, and somebody's immune system from the perspective of, like, if they get the flu, are they like somebody else who gets the flu? They've usually reached that milestone. Like, yes, can you still wind up admitted to the hospital with the flu? Yes. Are you super likely to wind up admitted to the hospital with the flu once your immune system is reconstituted to certain milestones and you've been vaccinated? No, hopefully not. So by 9 months post-transplant to 12 months post-transplant, typically we hope to see normal T cell function and becoming independent from IVIG. That's sort of ideal,
scenario.
best case scenario. I think there are a fair number of boys transplant for Wiskott who that next milestone we look to see is freedom from IVIG by 2 years post-transplant. And there are a fair number of patients who take that sort of extra year and 3 months to get to that milestone.
Yeah. So Mati, I would like to ask 2 more questions. I don't know if we can stay on.
I think we can, Dr. Prokop. Would that be okay with you?
Yeah, that's totally fine.
Perfect. Go ahead, Dr. Kendall.
So one is about mental health issues. How common are those after transplant, or is there a part of the program that really takes care of those complications?
Yes, they are common. I think that we underestimate the extent to which this is disruptive for families, disruptive for normal sort of socialization with schoolmates, with friends, for the normal both separation and non-separation from kids' parental units, depending on how old they are when they're going through this. We have a dedicated psychologist as part of our survivorship program. Most of what they do is try to make sure that referrals to community-based therapy happen. So whether it's a school-based counselor or somebody in the community, but we find that people don't necessarily want to keep coming back here every week for therapy or something like that. But really being integrated with school-based therapy and work-based therapy has been the most successful.
Okay.
But I don't think there should be any, this is common. This is a huge event for a family. And I think when you have people like me saying, if you have mixed chimerism, we don't know, you sort of live with that feeling that another shoe could drop. And so figuring out how to live life normally, both without totally ignoring that you've been through this, but also recognizing that the majority of boys do really, really well and don't need like major interventions to stay healthy.
Okay. From the chat also, are you aware of data comparing the side effect of busulfan in transplant and those of a lower dose that is used in gene therapy? Is there data that has compared those?
It's really hard because there isn't great data comparing those. There's a prospective trial in SCID comparing moderate dose to low dose busulfan. That's, I think, the closest that we will be able to get, because the difference is that transplant typically includes other agents besides the busulfan, in addition to the risk of graft versus host disease and the risk of rejection and mixed chimerism. And so just pulling out the busulfan dosing is very challenging from that perspective.
There is a group of questions about vaccines, prophylactic antibiotics, but those, Sumati, I think those are general questions and not really post-transplant. I don't know if I read them correctly in the.
I can say one thing about vaccines.
Yeah.
I think from the perspective of somebody who cares for patients with immunodeficiency all the time, I worry a lot about a less vaccinated world. But the other part of this is we here, me in collaboration with a couple of our immunologists, have really changed our thoughts about vaccinating people who are on Hizentra or IVIG post-transplant. And so we have started to be more aggressive about vaccinating people, even if they're on exogenous immunoglobulin, with the idea that you can get T cell protection from those vaccines if your T cells are functioning normally. And that IVIG appears to be a little less effective in terms of preventing pneumococcus than some of the other vaccine preventable infections. And so we have actually, it's in the last year, sort of changed and started to be more aggressive about vaccinating people, even if they're on IVIG. Not if they're on IVIG for like 3 months and we expect they're going to get off and then get vaccinated normally, but if they're on for longer, we're being more aggressive about it.
Dr. Kendari, there were 2 questions on vaccines that I wanted to ask, specifically for the Wiskott group. If you're splenectomized, how important is it to maintain prophylaxis and get your vaccines? And the second is there a relationship between vaccines and infertility?
So the second, there is no relationship between vaccines and infertility. I know this came up a bit also with the RNA vaccines around COVID. There's no relationship. And vaccines are safe even during pregnancy. Or some vaccines have been established to be safe even during pregnancy. For the splenectomized patient, it's a little bit controversial. So the use of prophylactic antibiotics long-term is stopped by most adult programs by 10 years after a splenectomy. In pediatrics, we maintain prophylactic antibiotics at least until somebody is fully vaccinated and has shown titer response to those vaccines. But it does become that much more important to both have vaccines and have titers showing response to those vaccines, because that is a population that not uncommonly needs extra boosters.
Thank you. Because we were told that for Wiskotts, it's a lifelong prophylaxis. It's required after splenectomy. So
That's what I do, but I see quite a few patients who come back to me and are no longer on it. So I'm trying to thread that needle. I don't think it's universal.
Okay, I think we have gone through most of the topics, and I don't know, Sumati, did we miss something?
No, I think we've covered the gamut. It was great to hear this detailed talk on post-transplant and the complications, the possible challenges.
Great. So thank you again, Susan. That was very, very informative, and clearly has been well received by the audience. So thank you again.
Thank you. Thank you so much. Thank you, Dr. Prakop. Thank you, Dr. Kendari, so much for both of you for taking your time on a weekend to join. And thank you, of course, to all our patients and families, and particularly the HIGM and SCID families who have also joined us today. Thank you very much for joining us. And, we would appreciate if you could help us continue our mission. We're a volunteer-run organization, and if you could volunteer, donate, all of this can help improve the lives of our patients. And please feel free to reach out to us at any time and let us know how you can help. And with that, I just want to say thank you to everyone and have a wonderful rest of the day, evening.